In 1775, a London surgeon named Percivall Pott noticed something strange. Young boys who worked as chimney sweeps were developing a rare, often fatal cancer in a place soot would never normally reach. It was one of the first times anyone had proven that something in a person's environment, not fate, not bad luck, could actually cause cancer. That single observation, made nearly 2.5 centuries ago, would take generations to fully explain, and it would help reshape how humanity understood one of its oldest and most feared diseases. Cancer is not one disease, but more than 200 distinct ones, unified only by cells that have stopped obeying the rules that normally control growth and division. According to the World Health Organization, cancer is one of the leading causes of death worldwide, responsible for millions of deaths every year, and nearly everyone alive today either has been personally affected by it or knows someone close to them who has. Few diseases in human history have been simultaneously this ancient, this universal, and this misunderstood for so long. The earliest known written description of cancer appears in the Edwin Papyrus, an Egyptian medical text dating to around 1600 BCE, which describes 8 cases of breast tumors treated by cauterization, and notes plainly, for one case, that there was no treatment. Around 400 BCE, the Greek physician Hippocrates gave the disease the name history would remember it by. Observing that the swollen blood vessels around certain tumors resembled the legs of a crab, he called the condition karkinos, the Greek word for crab. Roughly 5 centuries later, the Roman physician Celsus translated the Greek term into Latin as cancer, the word still used today. For well over 1,000 years afterward, the dominant medical explanation came from the Greek physician Galen in the 2nd century CE, who taught that cancer resulted from an excess of black bile, one of the 4 bodily humors believed to govern all illness. Galen's black bile theory would remain the leading explanation for cancer in Western medicine for more than 1,300 years, shaping how physicians diagnosed and treated the disease well into the Renaissance. For most of that time, treatment options were brutal and largely ineffective. Physicians attempted to purge the body of excess black bile through bloodletting, laxatives, and induced vomiting, based on the belief that rebalancing the humors could cure the tumor. Surgery, when attempted at all, was performed without anesthesia or any understanding of infection, making it agonizing and frequently fatal in itself, reserved only for tumors that were visible and accessible near the body's surface. A cancer diagnosis carried enormous stigma and fear. Many patients hid their symptoms rather than seek treatment that offered little hope and considerable suffering. The idea that cancer might have an external, identifiable cause, rather than simply being a matter of internal imbalance or fate, did not seriously enter medical thinking until 1775, when the English surgeon Percivall Pott studied an unusually high rate of scrotal cancer among young chimney sweeps in London. Pott connected the cancer directly to their prolonged, repeated exposure to soot lodged in their skin from years of climbing inside chimneys as children. It was the first time a physician had identified and documented a specific environmental substance as a cause of cancer, a finding now recognized as one of the earliest examples of occupational cancer research in medical history. The next major shift came nearly a century later. In 1858, the German physician Rudolf Virchow proposed that all cells arise from other cells, a foundational idea in what became known as cell theory. Virchow argued that cancer was fundamentally a disease of abnormal cell growth, not an imbalance of bodily fluids, a reframing that laid the scientific groundwork for how cancer would be understood from that point forward. Treatment began to modernize alongside this new understanding. In the 1890s, American surgeon William Halsted pioneered the radical mastectomy for breast cancer, an aggressive surgical approach that, despite being disfiguring, dramatically improved survival compared to earlier methods and became the standard of care for decades. Just a few years later, in 1895, German physicist Wilhelm Röntgen discovered X-rays, and in 1898, Marie and Pierre Curie discovered radium. Within a matter of years, physicians began using radiation to treat tumors directly, giving rise to the field of radiation oncology. The next transformative leap came in the 1940s. Researchers studying the effects of nitrogen mustard, a chemical related to World War I-era mustard gas, noticed it dramatically suppressed white blood cell production, leading physicians to test it against lymphoma. In 1947, physician Sidney Farber achieved something previously thought impossible. Using a folate-blocking compound called aminopterin, he induced temporary remission in children with acute leukemia, a disease that had been considered universally and rapidly fatal. Farber's work is widely credited as the birth of modern chemotherapy, and childhood leukemia would go on to become one of oncology's greatest treatment success stories in the decades that followed. It took until the 1970s to understand what was actually going wrong inside a cancer cell at the genetic level. In 1976, researchers Michael Bishop and Harold Varmus discovered that normal genes already present in healthy cells, called proto-oncogenes, could be mutated or damaged in ways that drove uncontrolled cell growth, transforming a normal cell into a cancerous one. Their discovery, which earned a Nobel Prize in 1989, reframed cancer as fundamentally a disease of damaged genes rather than a single external invader, and it opened the door to therapies designed around a tumor's specific genetic mutations rather than a one-size-fits-all approach. That shift culminated in 2001 with the approval of imatinib, marketed as Gleevec, a drug designed to specifically block the exact genetic mutation driving chronic myeloid leukemia. It transformed a once-fatal blood cancer into a manageable chronic condition for most patients and became the model for the entire field of targeted cancer therapy. More recently, researchers James Allison and Tasuku Honjo discovered how to unleash the body's own immune system against tumors by blocking specific molecular brakes on immune cells, an approach called checkpoint inhibitor immunotherapy that earned them the 2018 Nobel Prize. Despite this progress, cancer's toll remains enormous. According to the World Health Organization, cancer causes nearly 10 million deaths worldwide every year, making it one of the leading causes of death globally. Lung cancer alone, closely linked to tobacco smoking after the connection was firmly established by landmark research in the 1950s and confirmed in the U.S. Surgeon General's 1964 report remains one of the most common and deadliest cancers worldwide. Cancer's reach touches nearly every organ and every population. And despite over 2 centuries of accumulating scientific understanding since Pott's Chimney sweep observation, it remains one of the defining medical challenges of the modern era. Modern cancer care looks almost unrecognizable compared to a century ago. Screening programs like mammography, pap smears, and colonoscopies now catch many cancers early enough for far more effective treatment. In 1971, the U.S. National Cancer Act, signed by President Nixon, dramatically expanded government funding for cancer research, launching what became widely known as the War on Cancer. Today, oncologists routinely sequence a tumor's genetic makeup to select therapies tailored to its exact mutations, an approach that would have been unimaginable to physicians even a few decades earlier. Yet access to this modern standard of care remains deeply uneven around the world, with survival rates varying dramatically between wealthy and low-income countries for the exact same diagnosis. Put the two eras side by side. Before, a patient in the 18th century who noticed a growing lump had almost nowhere to turn. Physicians could offer bloodletting to rebalance the humors, cauterization, or crude surgery without anesthesia, and a diagnosis was so feared and stigmatized that many patients concealed their symptoms until it was far too late for any intervention to help. Nobody could explain why the tumor had appeared, and almost nothing could reliably stop it. After, a patient today with the same growing lump can access imaging, biopsy, and genetic sequencing within days, often followed by a precisely targeted therapy chosen specifically for the mutations driving their individual tumor, developed using scientific understanding that traces directly back to Virchow's cell theory, Farber's chemotherapy breakthrough, and the oncogene discoveries of the 1970s. Survival rates for many cancers, including childhood leukemia, have transformed from near-certain death to routine long-term survival within living memory. The tumor cells themselves work exactly the way they always have, driven by damaged genes multiplying out of control. What has changed is nearly 2.5 centuries of accumulated science, starting with a London surgeon's observation about chimney soot. None of this means cancer is solved. It remains one of the leading causes of death worldwide, and for many patients, especially in under-resourced regions, the gap between what modern medicine can do and what they can actually access remains dangerously wide. Hippocrates named this disease after a crab because of how it looked on the surface of the body. Today, physicians can watch it unfold at the level of a single mutated gene. The distance between those two ways of seeing the same disease took nearly 2,500 years of human observation, error, and slow accumulation of evidence to cross, and the journey from a crab-shaped tumor to a targeted molecule is still, in many ways, not finished yet.